I've had this conversation many times with peers, family, friends, and I think it's time to go ahead and do a video on it. What is it truthfully like to work as an RN or as a PCA or as a staff member in a psychiatric inpatient hospital on a high acuity unit? And I'm going to be going over some of the do's and don'ts in the hospital and ways that you can ensure safety, and I'll go over some differences in regards to if you're thinking about wanting to work in the field. But I believe this video is crucial to anyone who is wanting to go into the field of psych, especially on the inpatient side, and to give tips to people out there who currently work in psych who feel like they are in environments that could escalate into serious situations. So we'll be covering that as well. How to stay safe, how do staff stay safe in a high acuity environment, how do I stay safe, how do my peers stay safe, and ultimately, how do we keep the patient safe? Please like and subscribe to the channel. Let's jump right on into it. So let's start with what a typical day would be like for me when I walk into a psychiatric facility, and more specifically, I go check in the break room what unit I'm on, if I'm on the high acuity unit, what my day would look like. So let's start with this. First things first, when I go see that I'm on the high acuity unit, right after that, I go to the report room where I get report. And this is, in my opinion, probably one of the most important parts of my day, regardless of what unit I work on, but in particular the high acuity unit, or high acuity units. This is probably one of the most important, at least for me. When I get report in the morning, sometimes nurses want to go through report really quickly, but if I'm looking at the board, which is our bed board, and it says by the patient's name if they're involuntary or if they are flight risk and elopement risk, if they have an IM backup, I always look at that, and then I'll ask the nurse questions if she doesn't go over that with me. I always ask for each question. I always ask after I get report from the from the nurse. I always ask, were any of the patients aggressive? Were any IMs given? The reason being too, it's because a lot of times nurses, they won't give you that in the report, and that can be very, very dangerous if you do not know that. So if the night before a patient got a shot and the nurse that's giving the report in the morning doesn't tell you that, sometimes they don't do it just because, and they're like, you need to read the report book. But I always ask those kind of questions. So listen in your report, or what I do is listen to my report, and I always ask questions. And then after that, after I get report, so I have let's say my 10 patients, I have a breakdown in each one. First thing that goes to my mind right after I leave the report room as an RN is which patient needs to be seen first. Or, matter of fact, sometimes how it works in one of the facilities I work in, first thing you do is pull your meds. If there's a specific patient that I know needs PRN meds or a patient that could escalate, I always pull their meds first to have them on board, in particular their PRNs, because most of them do have morning meds, so I pull them. But that always is running through my head as well, is what is the situation right when I go to the unit after report. So pulling meds, starting to pull meds, and while I'm pulling meds as well, and even a little prior to that, right when I leave report, I'm always thinking, is there anything that needs to be done right now? Because sometimes there are, let's say a patient needs to discharge, and you're not told this, or the nurse says, yeah, this patient's got to discharge at 7:30 in the morning, and you leave report at 7:20. That's the priority. So it's always priority thinking. But let's say there was a discharge that was leaving at 7:30 or 8 in the morning, and a patient escalating. Which patient would you see first? The one escalating. The discharge can hold off, or you can ask for help. After this, I pull my meds, as I said, and if nothing's going on, I always like to, right after pulling my meds, walk around the unit and do rounds. And not even if I'm even just taking rounds myself on paper, but mentally, okay, seeing if there's anyone in there on my side, if there's anyone in their room doing anything, or if they're not going to the cafeteria in the morning, what's going on. So kind of getting an idea, just kind of how the flow is going to be, if patients are isolating, if patients, the way they talk to me, their demeanor, little things like that. So after they go down to breakfast, I have the meds pulled, and what I typically do after this is I start my assessments. And in particular on the high acuity unit, the assessments can either be very short or they can be a long time, because if you get a patient there that is a schizophrenic or a patient with schizophrenia, one thing you'll realize, or if they're hyperverbal and have schizophrenia, you might be doing a long assessment, so you've got to redirect them a lot. So assessment, and while I'm doing my assessments on my patients on this unit, you're going to get a lot of times delusional statements from them. You have to understand that when they're saying these, it can be sometimes quote unquote funny, some of the stuff, but you need to always take everything they say as serious. So let's say when I'm asking if they're suicidal or homicidal, they go, no, I'm not suicidal or homicidal. However, I do sometimes think about killing someone, blah, 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 go on like that. Even if they're still saying, no, I'm not currently, they could still passively be homicidal or passively suicidal. Do my assessments. After this, typically, once again, I always like to, as I'm doing my assessments as well, I like to talk to the patients a lot. Talk to them. And talk to them in a way where I'm forming a therapeutic relationship with them, but also establishing boundaries, therapeutic boundaries. Meaning, your patient is your patient, but there's a way to talk to them where you don't look down upon them, but also at the same time, or by the same token, you don't want it to sound like you guys, like you're just chatting friendly to a point of where it's more of a friendship than a therapeutic relationship, if that makes sense. So I always like to have casual conversations with them and talk to them at the same level, because that's how they'll form trust with you. They'll tell you what's going on with them more than likely, and they'll even tell you if they're having problems with anyone out in the milieu. So that gives you a better idea of potential situations of what could happen throughout the day. So that's really important during the assessments, is forming those therapeutic relationships. So, and at the same time, some patients won't actually want to come up to the nursing station and get their meds, and you'll have to go to their room, and they might tell you, shut the fuck up and get out of here. And if they say that to you and they're being aggressive, just, okay, if you want them, let me know. Walk away. Do not go engage and go into the room by yourself, which we're going to talk about a little further. I've got with the board where I have do's and don'ts, where we'll be discussing more. So never put yourself, try to be alone where you go into a patient's room alone, which we'll discuss a little later. After my assessments, I look and see if I have any discharges, and from there, and get those done, and then from there, admissions. So big thing when we get new admissions coming in throughout the day, there's a balance that has to be made, and you really have to be on top of your game, because when you have a new patient come to the unit, let's say you can't see them for 15 or 20 minutes because you're doing something else. Typically, if I'm busy, I will always at least try to say, hey, my name is Adam. I will be your RN for the assessment. If you want to hang out right here at the nursing station for right now until I can get to you, I greatly appreciate it. One reason I do that is because even if their room or bed is available, and let's say they're not sleepy, if they're sleepy, that's one thing, but if they're wide awake, the reason why I like them to stay up there is because while I'm doing things, I can still keep an eye to see if there's anything abnormal going on. Because if you just let them go to their room, there's only so much you know about the patient before they come to the unit. Who knows if they could try something? That's the whole thing. So I like them to sit at the nursing station. And then from there, outside of the admissions and getting to, really get to know your patients, form therapeutic relationships, watch them in the milieu, communicate with the PCAs. The reason why I brought up the PCAs a little earlier ago was because PCAs are doing the rounds. They're talking to patients as well. They're doing a lot of the same stuff the RNs are doing, besides passing meds. So that's big. So what I'll tell you real quick before I go into the do's and don'ts is when the day's wrapping up, when I go into my report, when I give report to the nurse, even if I'm tired, if it's been a long day, If I need to give a decently long report and give detail, I will always do that because it's a safety thing. So if multiple patients have been reporting, they don't like such and such patients, I need removed out of this room, I need this, I need that. You always want to let the nurse know just so they have an idea. Or if a patient's you could see kind of escalating throughout the day and can go off just like the flip of the switch, that would be another thing I would always bring up and report to the nurse. And you always want to communicate that with them. And I always, even if they weren't there the night before, I always tell them out according to the bed board. This is who's involuntary, who's voluntary. So it's all about communication. Lastly, before we go into the board, it's called the board, where I'm going to be going over the do's and don'ts. Always remember that if you haven't worked in psych before and you're wanting to work in psych, the reason why I give you this day-to-day on a high acuity, which I'll be discussing in later videos, what it's like to work on the substance abuse unit, or just like a more calm milieu setting where there's not aggressive patients or patients with psychosis or schizophrenia. I tell you this just so you have an idea of when you get into the setting, what it's going to be like. And some of them can be similar. I won't lie to you. Some psych facilities, depending on the one, can actually have similar structures to the jail setting. Now, not all of them, but there are some that are like that. So just always remember as well, if you're wanting to go into it, if you're wanting to go into psych, you need to understand that there will be situations you will run into where you will have to put patients in holds, you will get yelled at, you will probably get spit at, and on top of it, you will be, if you get anything out of this video and you're thinking about working in psych, 9 times out of 10, if you're new and when you start in a psych hospital, there are patients who go to the same hospitals a lot, so they know the staff, and if they see a new staff member, they will be testy with you. They will try things, meaning if they know there's 4 cigarette breaks throughout the day, they'll be like, hey, can I get a 5th? Or they'll try to sweet talk you, or even big thing for men or even women, they'll try to get you to be like, hey, can you come in my room for a second to help me with something? You'll do that, everything's cool, and then they'll accuse you of something. So I just tell you that as some advice if you're wanting to work in psych. But now let's jump right into the board, which is the most important part in my opinion. I'm going to go over it pretty quickly. It is how to maintain a safe environment. It has some do's and don'ts, and how you ultimately stay safe, as well as keeping the staff safe, or your peers and your patients safe, but more than anything, yourself safe. Let's jump right on in. Okay, so here we go. So this is probably one of the most important parts, if not the most. You might be asking at this point, why haven't you talked about how to stay safe? Well, here we go. How to stay safe, how for yourself to stay safe as a staff member, or for you as even advocating, or your patients, how can you keep them safe or your staff stay safe? Number 1, communicate. Once again, communicate. Let staff know when interacting with violent, aggressive patients. Remember, this is all talking about how to stay safe. What is it like on a high acuity unit? High acuity, key word, but a lot of these apply to all units, but in particular high acuity. Communicate. So as I was saying earlier, as I was going to discuss briefly, if you were going into a patient's room, or you're needing to do anything one-on-one with a patient that has a history of aggression, or you don't know them, always, if you can't get another staff member to help, if they're asking you to go in your room, what I do is I put one foot in the room and keep 1 foot out, so I'm still on camera. But always communicate with your staff and peers when you have a violent or aggressive patient. So communication, so everyone's on the same page as well. Huge. Number 2, receive a good report. I talked briefly, I always try to give a good report. You should always, this goes for the PCAs and the RNs. PCAs should be getting report as well from the PCs directly or from the RNs, but where I work, by the PCs do it, give report to each other. And always, I was a PCA at one point and a CNA, always give good reports, because remember, us as RNs, and in particular as PCAs or CNAs, they're going to be spending majority of the time with the patients doing rounds and everything else. So let them have we need to make sure everyone gets a good report. Number 3, avoid closed, secluded areas. If alone, as I talked about with communicate, I kind of put those together. Never Never be in a secluded area if you know they're aggressive or just in general, because you don't know what could happen in that situation. Always be on camera. If you can't have somebody help you, meaning a staff member, or say, hey, wait, I'll help you with that, but I want a staff member here as well. Number 4, be careful with wearing accessories. This is huge. Right here, accessories. Injuries can happen. And let me give you an example. So this was a couple years ago. I always used to wear my name badge right here, on my shirt up here. And sometimes I get stuff, I've gotten patients and people ask at work, where's your name badge? Why they can't see it down there. And I always try to make it apparent and tuck my shirt in now. But you always have to remember accessories. If you have an aggressive or a patient in psychosis, if you have one of these patients, they could be hearing voices and whatnot. And one time for me, they took my name badge and it's a long string, they pulled it and tried to wrap it around my neck. So you have to be careful with your accessories. Whatever you bring, remember, they could end up taking it from you and using it. Never keep scissors on you. That's one big thing. Unless you have to do a procedure, do not keep scissors on you. Cell phones, if you're in a code, put your phone down in the med room first, because when you go into a code, it could be broken, they could take it. You just have to be careful with accessories. Watches as well. I know we need watches. I don't even wear a watch in the psych field there, because who knows, they could either take it and use it as a weapon or hurt themselves. And same with necklaces. I do wear a necklace to work. Main reason being, I like wearing it, but I keep it tucked in. But that is something I always have to keep in the back of my mind, that a patient could take that and try to use it. If it fell off for whatever reason and a suicidal patient took it, they could try to choke themselves, or they could try to choke me with it. Number 5, use de-escalation. Always use de-escalation. Either, first off, if a patient starts going off on you, you never want to go, I'm going to put them in a hold by yourself. Never put a patient in a hold, a physical hold by yourself. You need other staff. But also, if a patient's escalating, first thing you want to do is try to de-escalate them. Ask them what their problem, what's going on, what problem are they going through right now? How can we help them? Talk to them, because if you talk to them like a normal person, as I said earlier, they will respect you a lot more. Number 6, always have an escape plan. Know your exits. This is huge. I know it kind of looks bad being an escape plan, but when you start at a psych hospital, or if you're currently working at one, always know your exits. Always do. For example, when I walk in and out of the psych hospitals I've worked in, I've had a situation where I had a patient who was stalking me and saying, I'm going to kill you, blah, 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 which is scary to know. But what I did do is I always take a different exit to the parking lot, or I always park in a different spot. Also, when you're on the unit, you just want to know the layout of the unit, just in case there is a fire or there's something going on. You want to know where to take patients, and you want to just know how to stay safe. So always know your escape plan, know your exits. If the patient gets something that's very dangerous, a knife or something, you want to know your exits. Number 7, avoid sitting by exits. Another big one, near exits, patients will elope, and they will elope. So if you sit by exits and you're on a high acuity unit, a lot of times they're elopement risk. Not all the time, but a lot of times they don't want to be there, where they're hearing voices. They'll try to get through that unit. If you sit near an exit, they catch on how we go in and out, they will go right past. And they will go, and they will. So anytime you see that it's an elopement patient on the board, and I assume everyone's an elopement risk personally a lot of times, in general, if I don't know the patient or the history, be very careful. When you're going through the doors, when you open a door with your badge or however, or your wrist, like these wrist badges, always when you open it, just make enough room for you to slide in and shut that door. Because here's the thing, a lot of the doors don't shut completely. Like, they can catch it, or if they don't click, they can just walk right out. And 2 last things, always remember, as stated, safety is always the priority. Safety is always the priority. Safety is always the priority. Get it down, keep it in your head, do not throw the damn key away. Number 1, safety. Yourself. You protect yourself. Tell your management if you feel you're in an unsafe situation. Let them know, let management know. But your safety is always number 1. Followed by, and this goes with it, your staff and patients. All of these are a priority, but always remember at the end of the day, safety. Yourself, staff, patients. Or it can be any way in this order. But safety. And finally, remember, this population on the high acuity unit is there for a reason. For example, schizophrenia, sometimes bipolar if they're aggressive, psychosis, right here. More importantly, drug-induced. Drug-induced. And history, once again, of violence. Remember, this is why safety is important in every unit you work in, or in psych, or in a hospital, wherever you work, safety is big. But if you're working in a high acuity unit, these are the things you must do if you want to be successful and be safe long-term in the field. You have to know how to talk to patients. You have to know your surroundings. You have to know if there's elopement risk. If there's elopement risk, there's a lot that goes into it. You just have to understand these things. This is huge. And this will wrap up this video, but just follow for the next video. I will be putting out a video on what it's like to work on the substance abuse unit. That'll be dropping within the next week. I have a video on dissociative disorders that'll be dropping very, very soon as well. And lastly, I will also be doing a video on some general herbal supplements that help people going through detox in general. And this goes from alcohol, methamphetamine, heroin, that can help long-term and that are healthy for you, that can help and assist in your recovery. And what has actually helped me in some of my problems in my past with my recovery, different herbal supplements. Love you all. Please like and subscribe to the channel. Thanks again for watching it. Leave a comment. I love you all. Let's have a great night, great day, whatever it may be for you. Just know you do matter. I love you.